for some more people to log in?
I think we'll start and I'll introduce
Fine, no
our
problem.
presenter
Sure.
also, Dr. Chandanmeet Kaur from GNC Jammu. And she's going to be presenting this case. So, Dr. Chandanmeet, you can go ahead.
Yes, sir. Good evening, sir.
Hi,
Uh,
good evening.
so I would like to start my case presentation. My patient is a 20-year-old male who presented to our OPD with the chief complaints of diminution of vision for last 3 years, which was painless in nature and gradually in onset. Patient was in usual state of health 3 years back, where he noticed diminution of vision in his both eyes, which was painless in nature and gradually in onset. Patient also complained of difficulty in reading. There is no history of any difficulty during night vision. There is no history of any waviness in the vision. No difficulty in seeing in bright light. There is also no history of frequent change of glasses and no history of difficulty in dark adaptation. And there was also no history of any flashing lights or seeing moving black objects.
Okay, I can just
Past
go back to the previous slide. Okay, so
this one, sir.
if I have to like go by point wise, why do you want to roll out all those negative history like difficulty in night vision? Why is you feel that that's relevant in this case?
Yes, sir. So talking, if we see the age group of the patient, such age group patients complained of diminution of vision due to the some diseases. Like in this age, they can complain, they can have some refractive error, they can have besides refractive error, they can have other conditions like retinitis pigmentosa, keratoconus. They can have any macular dystrophies. So to rule out all those conditions, we have to ask this history.
Basically, not macular dystrophy. When you're asking for history of difficulty in night vision, when the examiner asks, you need to be ready with all the differential diagnosis for the disease which can cause night vision problem, like retinitis pigmentosa.
Mendoza.
But
So
in this,
polyretinal stationary night blindness also.
yes, and
Yes,
vitamin A deficiency,
yes,
choroideremia, rod cone dystrophy, some of
yes,
the autoimmune retinopathies, and very high myopia, pathological myopia. So, okay, all this could be a differential diagnosis for night vision problem. Okay.
yes.
So in your case, I'll say it's unlikely to be RP. So why am I saying that?
Sir, in RP, because it is having the problem in night vision, and in my patient,
Okay.
there's a negative history of difficulty during night vision. In that, the main complaint is night
It's
vision
okay.
problem.
In early stages of RP, the night vision problem may not be there. Some of the milder forms of RP can present late. What else?
So
Which is
there
very
can be,
classic of RP, which will
so
straight
there,
away roll out. Yes.
there can be a problem in the dark adaptation.
Okay, so basically the RP patient initially the central vision will be good, right? So
Yes,
the
sir.
macula will be intact. Most of them have six vision. They usually present with a delayed dark adaptation time, okay, and a night vision related issues, okay. And this patient is telling this diminution of vision, so itself suggests this even central vision.
Yes, sir.
So RP patients in early stage, they'll never say my vision is, they'll say my vision is okay. They can read 6 by 5 also,
Yes, sir.
but they'll have mainly problem concerned with the night vision problem and also the side
Right.
vision. Okay. So these are some of the leading questions because when you present in an exam, some examiner, whenever you tell something, they may ask, why did you ask this? So you should tell only if you are able to defend your negative history. Okay. So similar way, why wavy vision is relevant in this case? I say it is relevant. Why?
Sir, but it's in the young male patients, we can have a condition by the name of central serous chorioretinopathy because of stress and all those factors. In young males, we can have central serous chorioretinopathy.
So
So
basically,
in
when you
that,
want to answer such question, you should not go to the specific diagnosis straight away, like central serous retinopathy or a specific one, pointing out on one particular disease. Of course, it can be a differential diagnosis. Basically, you should answer like, so for wavy vision, I would like to consider the diseases which affects the macula, like so and so. So in that way, for you to answer also, it will be better, and examiners also will not have any, you can avoid additional questions. Because the moment you tell CSCR, your entire Viva might go in that direction. Okay. So that is one thing. Dr. Anuj, all of them are postgraduates, right? I mean, I presume
Yeah,
Yes.
most of them are postgraduate, but
postgraduates. Okay.
sometimes we do have consultants also joining in.
Okay, fine. No
But
problem.
yes.
So that I can, yeah, not an issue at all. Okay. So as I'm asking questions, if your people know the answer, you can type it in the chat box also. Okay. So that's the reason. Say similarly in the same difficulty in seeing in bright light. So could you please give me some differential? Because the entire case, the gist lies on this particular slide. If you can understand why we are asking history of each and everything, so you'll be able to answer most of the questions.
Sir, difficulty in seeing bright light also it can be suggestive of some fundus pathologies like retinitis pigmentosa, congenital stationary night blindness,
No,
albinism.
no, 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 no. See, difficulty in bright light is exactly, yeah, someone is mentioned like cone dystrophy, aniridia, very good. So, see, just think logical. Difficulty in bright light means which part of the eye is intolerant. I mean, we have different, right? Cornea, lens, vitreous,
Macula,
retina. In retina also, in macula.
macula.
In macula, there are rods, there are cones. So each starting from cornea up to the cones in the macula, if there is any defect in anywhere along the pathway, it can cause difficulty in bright light.
Bright
So
light.
corneal causes, obviously, it can start with the corneal erosions also. Okay. So if you want to consider the retinal differential diagnosis, what it could be? Someone has
Sir,
already mentioned.
sir, it is like albinism. It can be either
Yes, very good. Albinism. Excellent. Oculocutaneous albinism. We need to be specific. Okay.
oculocutaneous.
Oculocutaneous albinism. Then
Sir,
aniridia,
cone
cone
rod
dystrophy.
dystrophy.
Okay. So some of the drug toxicities in early stages can also cause the bright light intolerance could be a presenting
Chloroquine
symptom. Yes.
toxicity.
What about myopia? Myopia.
Yeah,
They tell us specifically, especially in the night driving and all that, they are little intolerant to the bright light, especially when they see the opposite light. So that also can be a thing.
differential.
Okay. So why frequent change of glasses?
Sir, again, if we see our patient is 20 years old male, so there can be frequent history of changes of glasses in condition like keratoconus.
Okay,
Such
very good.
explanations
Any
also.
corneal changes, problems, it can have these things. Okay, fine. So can any retinal disorders lead to change in glass power? Patient was wearing glasses, so, and suddenly it becomes a hypermetropic refraction. Anybody, I mean,
So one
that's if
in glaucoma also we find there is that
non-glaucoma, retinal causes.
retinal
Yes, yes, sir. Very good. Okay. So what happens? Whatever the
hyperopic
conditions which
correction.
causes the retinal focal point to shift little ahead. So either because of subretinal fluid accumulation, whatever the reason, you can have hypermetropic changes. Okay. Fine. So difficulty in dark adaptation, we have already discussed. Okay. So whatever that is related to the rod cone dystrophy group of disorders like RP, congenital stationary night blindness, vitamin A deficiency can have manifestation. I mean, a patient can present with difficulty in dark adaptation. So what about seeing black
Doppelganger.
dots?
Sir, black
இல்ல
so seeing like moving black dots can be seen in the condition again of
எங்க
our fundus like it can be seen in ocular toxoplasmosis condition. They can be main complaint of floaters.
So basically, that's what I told you. When you answered CSR, don't mention specific diagnosis. It should be a broader. So what's the cause for floaters? Whatever the opacity which
எங்கப்பா
is present in the vitreous
So they
cavity,
can be
that
in
can
the
cause.
vitreous. It will cast shadow over
பா
it.
Yes, okay, fine. Fine. So that's it. Basically, what I was trying to, tell you in this slide, depending on the your chief complaints, you need to know what particular negative history you need to ask. When you're presenting a case in an examination, unless you are not sure about that particular negative history, it's better to avoid that. Okay. For example, if the examiner asks the cross question, what could be the cause? Why did you ask wave vision? You should be in a position to tell. Just, don't tell it in order. This was not there, that was not there, and you need to know about each and every condition. Fine. You can go to the next slide.
Past ocular
No,
history.
someone is asking RP also myopic shift. No, that cannot happen suddenly. RP myopia is an association which can be there with an RP that will not cause sudden onset of myopia or a refractive shift. Yeah, fine. Next.
Past ocular history. There is history of using glasses for past 3 years. Family history. There is no history of similar complaints in any of the family members. And in the drug history is also not significant.
No, not significant or contributory. There is a
No.
difference, right?
Mm.
Drug history is significant, right? I mean, it's not contributory here. You understood the difference?
Yes, sir.
Okay, fine. So why family history is important here in this particular case?
General physical examination, vitals and systemic examination is within normal limits. Ocular examination, best credit visual acuity is 6 by
No,
36
no, you
in
didn't
right
answer.
eye.
Why family history is important in this particular case?
Sir, family history is important to see the pattern of the disease. There is the family we could draw
Inheritance. Autosomal dominant recessive. You also need to is in the patient, so the children can manifest that disease. They need not have.
in both eyes. And the vision is ocular movements were full and adequate, and interior segment examination is also within the normal limits. This is my fundus picture of right and left eye respectively, which I would like to explain. In the optic disc, the size is normal, the shape is also normal, and the color is slightly, there is temporal pallor, which we can see in both the fundus. Then margins are well defined, and ratio point, and AV ratio is 2:3. And talking about the macula, there is loss of the foveal reflex with a circular line, and in the surrounding we can see the whitish like spots around it, and there is also hyperpigmentation in between the circular lesion.
You can just go back to the previous slide again. Previous one. The vision. You can type in the chat box. See, you know the history now. You know the history of present illness. You know the vision, and you have seen the fundus. So it is important because one thing is it will give a cloak. No, it's not to rule out RP. In RP, if the macula is intact, the color vision can be totally normal. Okay. So if the color vision has to be abnormal, means which component of the eye has to be affected for the color vision to be abnormal? One is cones, other if there is any problem in the optic nerve. Okay. And also other cause could be congenital color vision problem. That is ruled out in this case because the onset of vision problem is reset and we have a macular changes. So for example, if I take this color vision, it's defective means it's that in case if you are presenting anything which is in the context of macular dystrophy, telling it as just defective may not be enough. You need to tell in the share how many plates was he able to identify. Okay, so whether it was, if they're not able to identify even the demo plate, then that will give you a clue about the thing. Understood? If they're, for example, if they're able to identify some 8 out of 21, then the disease diagnosis could be different. Why? Can anyone answer? Based on the color vision, same patient profile. Okay, so the fundus examination vision, everything is the same. But I have two patients. One patient says he cannot identify any of the plates in color vision. The second patient, like this patient, is able to identify some of the plates when you're checking the color vision, but not complete.
There are also some hidden plates in the Ishihara chart. Those hidden plates cannot be read by a normal person, but these color blind people, they can read those hidden.
No, that is in the context of color blindness. Color blindness is ruled out, right, in this patient because they cannot have macular atrophic changes and all that, and the history will be little different. So again, in cone dystrophy, there are two types. Okay, early onset and stationary, and late onset and progressive. Early onset and stationary is called achromatopsia, which is a stationary cone dystrophy, in which case they will not be able to identify any of the plates. Okay, whereas in late onset and progressive, they will have photophobia and all that, but they'll be able to identify some of the plates. So in this way, you can differentiate between an early onset stationary cone dystrophy versus a progressive cone dystrophy. Understood? Okay, so now why anterior segment examination is important in this case? So, for
Hmm.
example, let's say this patient we have not seen the fundus. Based on the history or keeping a differential diagnosis when retinitis pigmentosa or rod cone dystrophy. What anterior segment changes can they have?
Sir, like in keratoconus, there will be bulging. We can see the Munson sign on torchlight is
Okay, some of the RP patient can have an associate keratoconus as an
keratoconus. Yes, sir.
association
No,
because high
yes.
myopia is known to be associated with an RP
RP.
that they can have. Then what else? Is gonio important in these patients? If yes, why?
The glaucoma,
Okay,
like
what kind of a glaucoma?
sir, like if it was like congenital.
Hmm. So if even in case of a someone answered, it's an open angle glaucoma usually. And are there any inherited retinal dystrophies where the patient refraction can be hypermetrop with the narrow angles? Anyone? So one, if the RP and myopia is associated with open angle glaucoma, are there any retinal dystrophies which can be very good? Someone answered best disease. Can you specify which type of best? So in the best, there are two types, autosomal dominant best and autosomal recessive best disease. The dominant one is a milder form. They may have hypermetropic refraction, but usually they don't suffer angle closure glaucoma. Whereas there is one more entity called autosomal recessive best or bestrophinopathy. Usually they will have narrow angles. Okay. And most of the time, these patients require yak peripheral iridotomy. Okay. So that's why, though the case is, this is a macular dystrophy, you still need to pay attention to the intersegment findings. And also in cases of RP or rod cone dystrophy, what lens changes can be there? What kind of cataract is seen in these cases?
Sir, it can be posterior subcapsular cataract.
Yes, usually they will have a posterior subcapsular type of cataract. And also there are some syndromic conditions, right, which can cause both retinal and lenticular changes and all. Can you name some?
Sir, they can be like Usher syndrome, Bardet Beetle
Okay.
syndrome. Then it can be NARP. It can be Refsum disease.
Those are all the differential diagnosis for an RP. I'm telling any syndromic changes which can cause lenticular changes, changes in the lens, which can have findings both in the lens and also in the retina. Okay, Peters anomaly. Okay, any basement membrane disease, which can have
Sir,
renal manifestation.
it can be it is having posterior polymorphous Alport syndrome. It is having lenticonus and PPMD
Yes,
both Alport
exactly.
syndrome.
So those kind of things you need to know the differential diagnosis. Fine. Okay. So now go to the next slide. Now this is fine. Okay, people. Now go to the fundus one. Yes. So this fundus, whatever the description you are given for the disc and the blood vessels, all looks okay. But if you look at the lesion, would you like to, just forget what you are written on the slide? Just look at the slide and can someone else describe any other postgraduate?
Okay, I can try.
Yes, yes, please go ahead.
Okay, in the right fundus, I can see it's clear view, so the media is okay, and the optic disc looks well defined, no cupping, no pallor, well defined, and the color is okay, normal color. But I can see in the macular area well defined, um, pigmented flat lesion uh, with some RDE changes, and in the other eye also. Optic disc looks normal, but
RPE changes means what kind of RPE changes, sir? Okay, one thing you told, there is a lesion in the macular area which is well defined. That's an important point. Okay.
there is
And you are
a black
telling there are RPE changes. What kind of changes are seen here?
that hyperpigmentation of the eye of
Yes, there
the
are.
RBE, this
Yes,
black part.
yes, there are hypertrophic
Uh,
pigment
hmm?
clumps in that region. Okay,
Pigment clumps. Okay.
pigment clumps, and also there are atrophic changes also. Can you
Hmm.
make out? Okay,
Yeah.
and if you carefully observe, because of these atrophic changes, some of the choroidal vasculature also is slightly seen in those atrophic areas. Understood. So that's the
Yes.
description about the fundus lesion. So if you remember in our surgery, we used to take examination of the swelling. You remember? We just observe the surface, size, margin, and all that. Whenever you describe any macular lesion, especially the congenital one, same thing will hold good. First, look at it, comment on the shape,
Uh,
okay, and also the size, and also the
Rounded
border.
shape
If it's yes,
and
is it
like
horizontally oval or
three
vertically oval?
horizontally oval.
Yes, very good.
Size like 3 disc diameter,
Yes, okay. 3 disc diameter in the
and
horizontal meridian, in the vertically, it's almost 2 disc diameter.
the edges well defined.
Well defined. Okay. So now this is about the description of the lesion, what you are seeing. And on the base of the lesion, as I told, there are both hyperpigmentary and atrophic pigmentary changes, and also there are scattered pigment clumps. Okay. So this is about the description of the lesion. Now you need to go to the area which is adjacent to the lesion. How
Um,
is it?
in in the left eye, there is the yellowish lesions
Very good.
surrounding the uh, temporal part of the lesion.
Okay, very good. Whereas in the right eye also you can see, right?
And
Temporally, if you carefully observe, it is
yes,
bordered by a yellowish ring. It's not a complete ring, incomplete ring.
incomplete.
Okay, fine. So fine. So then that's about the description of the lesion. And in this case, what would you like to do next?
Sir, after that, we can do some investigations for the
Very good.
patient.
Like
Like we can proceed for OCT, then for fundus fluorescein angiography can be done.
fundus fluorescein angiography. Why? In this case, what additional information is it going to give? Because when we order investigations, we expect some additional information, right?
Dark
Someone
red,
answered no. Is fundus fluorescein angiography indicated in this patient?
fundus autofluorescence. No, fluorescein is
Yes,
indicated.
very good. It's a fundus autofluorescence which you need to do. Okay. So that is going to fetch you more information than fundus fluorescein angiography. But traditionally, in Stargardt disease, it's been described you can see a dark choroid because of the flex-like deposits. The
Blocking
flex
fibers.
seen in this case, block fluorescence. So that we no longer linked. But if some examiners ask you, you need to know that. Okay. So in this case, the flex are not that much, except that atrophic lesion, what you are seeing in the macular area, excavated lesion, there are not many flex in the surrounding region. Okay. And fundus fluorescein angiography unlikely to give an additional information. Whereas fundus autofluorescence can definitely give you the information. So what do you expect? First of all, what is fundus autofluorescence? Anyone else other than Chandan, Meet or Asmin? Someone, I think you stopped sharing the presentation.
Yeah, Dr. Hema, you can go ahead maybe. Dr.
Hema?
Sakshi, anyone?
Certain pigments produce their own fluorescence, like lipofuscin or some. They will have their own fluorescence.
Okay. So, for example, if a fundus, if you see a normal fluorescence, what does it indicate? If the fluorescence is normal,
And it's indicate normal retinal pigment epithelium.
does it indicate only normal pigment epithelium or something else also should be normal?
Photoreceptors.
Yes, very good. So basically, the normal fluorescence indicates a healthy environment between the photoreceptor and the retinal pigment epithelium. If this gets disrupted for whatever the reason, there could be hyperautofluorescence or hypoautofluorescence. This is the basic principle. Then whatever the changes you see, it resolves around this one. So for example, if there is a choroidal nevus, so what will be the autofluorescence pattern? You have a case of Dr. Prutin, you can answer. If there is a choroidal nevus and you do an autofluorescence, what are you likely to see in that case? Anyone else? In choroidal nevus, if you do an autofluorescence, will you get an hypoautofluorescence in that area or hyperautofluorescence or normal fluorescence?
Hyperautofluorescence with surrounded by hypoautofluorescence.
No. Why? Where is the lesion here? Choroidal nevus? Is sub RPE, right? So the overlaying RPE and the photoreceptors are intact. You can have a normal fluorescence. Okay, take another example. You have a chirp-like lesion. You know chirp, right? Congenital hyperplasia of retinal pigment epithelium.
Yes.
So what will you get if you do an autofluorescence in that area? Huh?
Hyperautofluorescence.
No, it's hypoautofluorescence. Why? Because it's only the hypertrophied RP. There is no photoreceptor over that. Understood?
Yes.
So to have a normal fluorescence, you need to have a both normal RP and a normally functioning photoreceptors. Okay, understood? So in this way, you can differentiate where exactly it's kind of, along with the structural information, it's also giving the functional integrity of an RP and the photoreceptors. Understood? So that's the basic principle of how an autofluorescence works. And now we can answer why is it important in this particular case. So one is the atrophic area can be better delineated when you do an autofluorescence test. So that is one thing. And the second one is if there are lipofuscin-like deposit, the flecks, what you call in a case of Stargardt disease, if they are very subtle, they may not always be seen clinically. But when you do an autofluorescence test, because of the increased lipofuscin accumulation, it will be become seen prominently when you do an autofluorescence test. Anything else which can be of use in this case? Why autofluorescence can be used in for this particular case? So to monitor the progression of the disease, okay? Because that is the question when these patients ask, right? When there is no treatment. So when you do a serial autofluorescence test, maybe over 2 years, the progression can be better monitored using an autofluorescence than a color fundus photography. Understood? So in the context of retinal dystrophies, be it retinitis pigmentosa, cone dystrophy, or Stargardt disease, or any other macular dystrophies or any dystrophy, the autofluorescence is something which is very important. Fine. So you advised OCT, fundus autofluorescence. What else? Other investigations would you like to order?
That electrophysiological tests, visual
Very good.
testing can be done.
What exactly is the which electrophysiological test would you like to order here?
Sir, multifocal electroretinogram.
Why multifocal electroretinogram?
Sir, because the full field it is for generalized description, but multifocal will particularly pick up the macular conditions.
So why do you need that multifocal ERG in this particular case?
The
Sir, to
lesion
detect
involved in the
is involved, that what layer is involved.
No, multifocal ERG is when you structurally, if you don't see anything, if everything is normal, then you do a multifocal ERG to understand the functional integrity. Here, the entire macula is atrophic, right, which is obviously seen clinically and also on OCT and autofluorescence. Multifocal ERG is not going to give you much of an information because everything is already atrophied. So multifocal ERG is mainly for predominantly for the posterior pole, right, macula. So multifocal ERG, and what is the one more challenge?
कितने दिन बाद मिल रहे हैं कितना एक महीना एक
So
महीना
patients will also have a difficulty in the focusing they will target will not be seen
ओके
because
अभी
the
कैसा चल
central
रहा
fixation is affected because of the atrophic macula.
20 चल रहा है
Understood?
कितना दिन हो गया
And why is fulfilled ERG important in this?
ओके एंड बाकी कैसा है
Why fulfilled ERG? Yes, very good, Dr. Kutinita. It is for the prognosis. For example, in this case, if the fulfilled ERG is completely normal, then that means the disease is limited to the macula, in which the prognosis is relatively good. The progression chances are less. Let's say if you do a fulfilled ERG, both scotopic and photopic components are affected, then the prognosis is relatively bad. Basically, it indicates though the lesions are just seen in the macula, the retina as such it is diffusely affected. So that's what it indicates. Okay, so OCT is over, autofluorescence is over, ERG is over. What else would you like to order in this case?
वो तो हमको पता ही है
The visual field.
तो अभी तो हमारे खत्म हो रहा है ना
So,
अभी शायद
Dr. Anuj, do we have time for 5 more minutes?
The visual field testing.
Visual fields, why in this patient? You want to order in this patient or something which is opposite to it? You order in rod cone group dystrophy group of disorder, right? Like retinitis pigmentosa. Because there will be progressive loss of peripheral vision. Okay, you need to monitor. When the central macula itself is affected, macular dystrophy, it is opposite to RP, right? The disease starts in the fovea. Okay, so visual fields may not be of much use. And someone is asking whether electrooculogram, not in this particular case. Electrooculogram we do only when you suspect the disease which is localized to the which part. So when you do an electrooculogram,
Retinal pigment epithelium.
yes, very good, retinal pigment epithelium. So whatever the disease which affect the retinal pigment epithelium, like Best
Best
disease
disease.
and also autosomal recessive bestrophinopathy, because these diseases happen because of the defective function in the bestrophin gene, which is localized to the retinal pigment epithelium. In that case, if the disease is not very obvious clinically, you do an EOG to confirm it. This case, Best disease is not a differential diagnosis because the atrophic area is quite large. Okay. So even the Best disease, when it reaches atrophic stage, and it is when likely to reach this stage in a 28-year-old patient is quite young, right? Right. Good. Someone is called FFA only if and Octa only if we suspect CNVM in these cases. So usually they develop CNVM at the edge of the cases, which is very rare in case of Stargardts or any central areolar choroidal dystrophies. Okay. Another thing is genetic counseling and testing. That is something very important. Why? Anyone else?
Sir, if one is carrier or both are carriers,
So we
then
need to
if
do
they are
genetic
marrying,
testing
further what is the chance
for,
of baby?
yes, I'll tell for a couple of reasons. One is we need to know the gene which is causing this particular problem. Okay, that is one thing. And the second, because the prognosis also depends on the type of gene and the type of mutation what the patient has. And the second thing is there any chance of next generation is getting affected? This is 20-year-old male, right? After some year, he will get married. He wants to plan family. And it's very important for us to, sensitize them regarding the role of genetic testing and the chances of offspring getting the disease. Okay, so that is one thing. And also third important from the research point of view, there are many gene therapy trials you must have heard, right? Which are going
Yes,
on.
sir.
So retinal dystrophies can happen because of more than 400 genes so far they have discovered. But gene therapy trials are available for only 10 to 15 genes. So if his genes falls under this 10 to 15 category, then definitely you can hope for something in the near future. And also other thing is, as someone has mentioned, like ABCA4 gene, which can cause the Stargardt disease. If the mutation is ABCA4, which what is contraindicated? What should not be done? For example, this is
Sir,
star. Let's
vitamin
assume this
A
is a star.
supplementation.
Yes, vitamin A should not be given. Should be given or should not be given?
Not be given.
Should not be given. Very good. Because excess vitamin A, because the enzymes which is there in the visual cycle, some of the enzymes are not efficient in digesting the toxic byproduct, metabolic byproducts of the visual cycle. And once you supplement them with vitamin A, there will be increased A2E or bisretinoid formation, which are toxic to the existing healthy cells. That's why you should avoid vitamin A or any other forms of micronutrient supplement. Okay, so that is one thing. That's the role of genetic testing. And genetic testing, you may get a question in the recent advances role of genetic testing, which are already described. One is to understand the root cause of the disease and also to know the prognosis and also to know whether to help patients in plan their families. And the last thing is whether is there any possible role of gene therapy for that particular gene, and what are the different ways in which genetic testing is done. Do you know? Can someone answer how a genetic testing is done different? If you want to do a genetic testing tomorrow, what will you write? Will you just write just genetic testing, or you need to mention something there, the type of testing? So it can be done in a different way. One is whole genome sequencing, where we'll end up sequencing both the coding and non-coding part of the genome. Whole exome sequencing. Our genes has got exons and introns. You remember? You must have read in 12th or in MBBS and all. Exons are the coding region, introns are the non-coding region. In whole genome, we sequence both exons and intronic portion of the DNA. In whole exome sequencing, we sequence only the coding part, that is exomic part. And there is one more called clinical exome and retinal dystrophy panel. When you write this thing, they will only look for the genes which are responsible for the defined disease. So when you order a genetic testing, you need to know what to expect and what to write. Okay. So accordingly, your geneticist or the lab will do the test. Okay. Fine. So the last part. So what are the differential diagnosis for this patient? You know the history now. You have seen the vision. You have the fundus findings. So what are the differential diagnosis?
So
Because in
there are
exam, you
other
should always give a differential diagnosis. Yes.
there are other conditions like fundus albipunctus, fundus.
Fundus albipunctatus in this case, will fundus albipunctatus have this macular atrophy?
Sir, it having flex, but they are not involving the fovea.
Yeah, of course. It's in this case, it's not only the fovea is involved, the macula is completely atrophic, right? So basically, you need to give a differential diagnosis of all macular dystrophy, inherited retinal dystrophies, which can cause macular atrophy. So can someone name all of that?
Cone rod dystrophy,
Someone else?
retinitis pigmentosa,
Okay, no,
best
not retinitis
dystrophy.
pigmentosa. Retinitis pigmentosa doesn't start with macular atrophy, right? The disease starts in the periphery, mid-periphery.
Sir,
You need
best
to consider disease. Okay, cone rod dystrophy. Okay, best disease.
disease.
Again, best you need to specify late or advanced stage of best disease. Okay, early stage it will have just a vitally formed like deposit, right? It will not have macular atrophy. Once it reaches to the later stage, there could be atrophy corresponding to that vitally formed deposit. Cone rod dystrophy, advanced stage of West disease. What else? Okay, someone said North Carolina dystrophy.
Sir, pattern
Fine.
dystrophy,
Then
familial
dystrophy, very good.
difference.
And someone has told central areolar, not central areolar macular dystrophy. It's called central areolar choroidal dystrophy. No, SARS-B is not. SARS-B is a pseudo-inflammatory dystrophy. There will be widespread fundus involvement and they will not have localized macular lesion. Stargardts.
Sir, familial Duchenne.
No, familial Duchenne will not have atrophic changes again. There will be deposits. So inverse RP, the term doesn't exist anywhere. Okay, of course, for the sake of answering, we can tell that inverse RP. Fine. So in this case, the most likely diagnosis is it could be a case of central areolar choroidal dystrophy. So the reason is there are no prominent flecks in the perimacular regions and the borders are well defined. If you do an OCT, that will give an answer to you because in central areal choroidal dystrophy, as opposed to the Stargardts, the choriocapillary and choroidal part will be completely atrophic and we'll see a well-defined area of hyperreflectivity when you do an OCT. So that is one. Of course, in exam, when you get these kind of cases, just give a differential diagnosis. You need not worry. I mean, you need not, point out that this is North Carolina. These are always mention differential. So based on the history, clinical examination, and based on the vision, sir, I have come to so and so conclusion. It could be a case of macular dystrophy. So the differential diagnosis could be Stargardts, central areolar choroidal dystrophy, advanced stage of pests, okay, cone dystrophy, inverse RP, North Carolina, all the dystrophies which can start with the macula, you can tell that. And you need to differentiate one by one. So it cannot be best. Why? Because the patient is still 20 years, right? You'll not have that much of advanced atrophic changes.
Also, vision remains intact till the later stages in this disease.
Yes, very good. And it cannot be North Carolina also. Why North Carolina? So what does it, North Carolina? North Carolina usually will have macular colobomatous lesion, okay? So which is not seen in this patient. So that is one thing. And it cannot be inverse RP, or cone rod dystrophy. Why? Because those patients will also have changes in the mid-periphery. In your patient, except the macula, the retina outside that atrophic area was quite healthy, right? So that is also ruled out. The only will boil down to only two things. Then the other thing is cone dystrophies. Cone dystrophies can also have atrophic changes, but it will not be that extensive the way you are seeing in your patient. It will be localized to the just the fovea, and the patients will have severe photophobia, which is absent in your patient. Okay. So finally, we come down to two things. Either it is Stargardts or central areolar choroidal dystrophy. And once you do the OCT, it will give us the clue, but the final confirmatory will be a genetic testing. Okay. So now, how will you treat this patient? With that, we can end the discussion.
Sir, well, there is no FDA approved treatment, but we can do that. We can avoid the vitamin A or any kind of those supplementation things. But sir, there are some drugs which are in pipeline. They are under trial.
In this patient, not the trial. At this point of time, what will you advise this patient? This patient is sitting in the clinic in front of you. You need to give some advice. One thing you are told, avoid vitamin A, considering it could be a Stargardts.
So then for
Next
vision,
thing.
we can think of low vision aids for the patient as
Before that, you need to give them dark glasses, right? Because you need
tinted
to protect
glasses.
because
Protect.
macula is atrophic, they'll be a little photophobic. And also, if it is a Stargardts, and Stargardts, the bright light is not good. Again, the same thing, whatever the vitamin A can do, the bright light also can do because it stimulates the visual cycle. The more the visual cycle runs, there are more chance of A to E bisretinoid accumulation, more damage. So dark glasses, you should avoid vitamin A deficiency. Genetic counseling is already done. Then comes the low vision aids, okay, which is very important. You should not tell this patient nothing is there. You can go home. You need to offer them low vision aids. Then visual rehabilitation. Okay, you need to sensitize regarding the rehabilitation services which are available and the possible certificates what he can avail. And the other thing, you need to counsel regarding the career. Okay, what they are going to choose, what they are planning, how their lifestyle should be. This is our responsibility. For example, let's say this patient is a taxi driver. Is it wise to somehow is able to manage because the places are familiar wherever he's driving. Okay, but it's not advisable for him, right? Or else he's still 20 years, he's aspiring to be a driver or he's aspiring to join the army. So that is the kind of professional counseling also you need to give. What kind of the jobs, what are the limitations they will have, not only in the job and also in the day-to-day activities, how it can be overcome and all. And then comes the research part of it. Okay? You need to do a genetic testing and recruit them and follow up them regularly. Okay? And also you need to counsel them regarding the consanguinity, the possibility of next generation getting it and all that. Clear? Avoid vitamin A, give dark glasses, low vision aids, visual rehabilitation, genetic counseling and testing, and also the career guidance, how they should plan their lifestyle and all. Okay, fine. So, any questions?
Yes, I just wanna confirm that to order the investigation in order. So first I have to ask for fundus autofluorescence. This is the first,
Yes,
right?
yes. And also the
Because
OCT. Yes,
and OCT early, like first start with fundus autofluorescence and OCT.
yes. Those are the
Then I
basic
can
investigation you do. Yeah,
then after that I can ask for ERG.
full field ERG. You need to specify the type of ERG, full field ERG in this particular case.
Okay. Um, Then visual field no need because it's starting macular lesion, so it's no need.
Yes,
And the EOG also no need because it is not originally retinal pigment epithelial disease. So
yes.
uh, fluorescein I need also to confirm or
Yeah, fluorescein only if you are suspecting any CNVM. If this patient comes with a recent history of trauma, the Brooks membrane, the macular region can be little brittle. If it breaks, can lead to secondary CNVM formation. So most of the time, OCT will be able to identify these changes at the edge. If you are still in doubt, then only you can do an FFA. Otherwise, there is no indication for fundus fluorescein angiography here.
okay, thank you.
And also the genetic testing. And someone is asking why fulfilled ERG? Because the fulfilled ERG represents activity of the entire retina. So other forms of ERG include pattern and multifocal ERG, which elicit response predominantly from the posterior pole. So when you clinically only can make out the macula is completely atrophic, your multifocal and the pattern ERG is not going to add any additional information. So the only thing in this particular case, I'm telling again, the indication differs from case to case. So in this particular case, clinically the macula is already gone. So you're likely to get an abnormal multifocal ERG and pattern ERG, which is known. See, whenever you do an electrophysiological test, the basic thumb rule is you need to get information which you cannot, get it by clinical examination or by a basic imaging like OCT or autofluorescence. You should give an information which is in addition to the OCT autofluorescence clinical examination. So that is the functional component of it. Because whatever the autofluorescence and OCT you give, it's going only the structural component. So that's why the fulfilled ERG is indicated because you need to know in some of the disease, what can happen is the clinically lesion can be seen only in the macular region. But only when you do an ERG, you get to know whether it's a localized disease or the entire retina is affected. There are many examples like achromatopsia, cone dystrophy, where the atrophy is seen only in the foveal region. But when you do a fulfilled ERG, you get to know that the cones in the entire fundus are non-functional. So that's the reason you need to order fulfilled ERG in this particular case. And I already explained why fulfilled ERG. Fulfilled ERG is normal. That means the disease is localized to the macula, in which the chances of progression are less. So any other doubts? Hope it was useful because dystrophy is something which is not usually there.
Absolutely.
Another
Yeah. Please go ahead. Yes, Dr. Yasmin.
Please go ahead.
uh, because this is the first time to hear about how to order when I am asking for genetic testing. So uh, we can ask specifically to write retinal dystrophy screening.
When no, when you order the genetic testing, first thing you need to give the lab the background information about the patient, what problem he has, what is the symptom profile, and what is the clinical examination findings. Okay, then as I already discussed, If you are very sure about the phenotype, it's a retinal dystrophy, you can go for retinal dystrophy panel, where they will check only those genes which are known to cause retinal dystrophies. Next comes the clinical exome sequencing, where they will look at all the genes which can cause clinical problem, all syndromic, ocular, non-ocular, everything they will test. The other is whole exome sequencing, where they sequence the entire exome, the entire coding part of the genome. So these three will be most of the time it will be enough. There is one more called whole genome sequencing, where they sequence whole exome and intron. That is only from the research point of view. So in this particular patient, since we are very certain either it's central areolar or Stargardts, we can go for retinal dystrophy panel.
Thank you, sir.
So what is the rough cost we are expecting for this
It ranges between 10,000 to 16,000. If you just go for a dystrophy panel, it will cost around 10 to 12,000. The whole exome sequencing costs around 15, 16,000, and clinical exome around 14,000 cost. If
Okay.
you go for the whole genome sequencing, it's little costly. It is more than 70, 80,000.
Okay.
But also the sensitivity comes down. The more you cover, it is lesser sensitive. So
Right.
that's why if you're very sure of the diagnosis, better to go for a specific gene panel, because the depth of sequencing will be better in the.
So it is like a step ladder, like if
Yes,
nothing
exactly.
comes up in this, then you go for a whole genome.
Go for this thing. Or if you are very sure of the diagnosis, sometimes what can happen, sometimes the patients can have an undiscovered mutations. In
Right.
those cases, it's always important and it's wise to repeat the genetic testing after 1 year or 2 year, because genetic database, it keeps getting updated. The genes which were tested 10 years back may not, that which must have come negative, now it may come positive. So this is something which you should always tell the patient. The fact that we are ordering genetic testing doesn't mean that we'll end up discovering the gene all the time. So in fact, the 40% of the cases we get either variants of unknown significance or no gene is detected. Only in 40-50% cases where we get a pathogenic mutation.
And the second thing is like from a practical point of view. Now, when if we are suspecting Stargardts, and if that comes, so what next does it change even for future family? Would you be screening as if it's like AR? Would you be, and if there is no phenotypical manifestation?
No, you should screen, because one is, if it's a Stargardts being a recessive disease, the patient is likely to have a homozygous mutation in ABCA4. So the spouse, even if the clinically normal, he or she could be a heterozygous carrier,
Right.
in which case they may not manifest the disease, but if these two genes combine, the children may become homozygous and may manifest the disease. So if it is more common, chances are high if it's a consanguineous marriage. But we have seen even in non-consanguineous marriage, since sometimes the ethnicity could be same, because of the common gene pool. So these patients could be asymptomatic carriers. So it's always preferable to check that. And in some cases, if the gene is inconclusive, it's also wise idea to check the parents. For example, if you have some rare gene, it has come as homozygous, which you are not sure, clinically you are sure. In that case, you need to check the parents whether they are heterozygous carriers for that particular mutation. So then that becomes more significant. Then you can go and screen the same in the spouse if they are planning for a family.
Okay. And is it common, like if we screen and we may get a mutation in ABCR4 without any phenotypical manifestation?
Stargardts is quite common, because ABCA4 is the most commonest gene what we get in a macular dystrophy, because of the Stargardts being more common. In ABCA4 it is true, but not true for other macular dystrophies or any other retinal dystrophies.
Okay. And second thing is what patients generally ask is, so gene therapy, I think, is out for Stargardts because it's such a big gene. Any experience with the stem cell therapy
No. Gene therapy is there for Stargardts. In fact, we are
okay.
starting the planning to start the gene therapy in
Very
next
good.
year. We have
Oh,
finished our animal trials. In a couple of years, we'll be starting the human trial for ABCA4 gene. It's a very large gene. We
yeah.
have our own patented dual vector strategy to cover this gene.
Okay. And what about stem cell therapy?
Stem cell therapy is in a very primitive stage. In the last RO meeting, what I attended ARVO, only the Japanese group has come with a retinal organoid which were tried in human, where the patient has some PL negative has become hand movements. So that's the only thing. There are many stem cell therapy, but when it comes to retinal stem cells, it's little complex. Because the retinal circuit is more complex than the cerebral circuit.
Right.
Because if you one unique area, if you take the retina, the number of synapses because of the 10 layers are more as compared to the cerebral. To design a stem cell which will go, first of all, it will go should get integrated with the host without rejection. Then it should synapse in such a way to resemble the original retina. And this synaptic activity, it should be in such a way that it goes up to the occipital lobe representation. So then only we can see. That's why little complex. That's why stem cells is in very primitive stage. Whereas other nanoparticle technology and gene therapy are seen more advanced as compared to the stem cells.
Actually. So that is
So,
very enlightening to know that we're starting with the gene therapy for
Yes. That
Stargardt.
will be the first gene therapy in India for the dystrophy, Indian made product, and first in the world for the ABCA4
Yeah,
when it
because,
happens.
because that was like a classical textbook answer that you should not
Yes.
say gene therapy for Stargardts, but you can say for
Oh, that
RP.
was.
But this is, I think, we've learned today. And does anyone have any other question before we let go of Dr. Purna Chandra because he has a busy schedule and he has spared time for us today?
Sir, can I ask something?
Please.
Yes, please.
Sir, like in gene therapy, you're talking about dual. Sir, we also have one lentivirus. It is also studied somewhere. It's also heavy.
No,
It can carry.
lentivirus is a type of carrier what we use for gene therapy. There are different viruses which can be used, but the most commonly used was adeno-associated virus. Because whatever the virus or carrier what we use, they need to have a special characteristics before we subject them for as use them as a vehicle for the gene transfer. They should be they should not have their own infective genes, and they should not cause post toxicity, and they should integrate well, and they should be stable to transport so that it can be transported from the manufacturing to the delivery site like that. So as compared to the antivirus, adeno-associated virus you're muted, Dr. Nujin.
I think if there are no other questions, then we will call it a day. And it was really amazing. And this is one topic which generally everyone fears, and nobody likes to go inside much other than the atrophy part. So one last word. So phenotypic, you would rate it more as a central areola or a Stargardts?
Oh, this is tolerable.
Okay.
This is tolerable.
So I think we'll just call it off, and maybe we'll catch up with Dr. Purna Chandra again for some other topic if he has time. And then thanks a lot. Thanks everyone for joining. And
Thank
Thank
you,
you
sir.
so much, and all the best.
thank you.
okay.
Thank you.
Good night.